So we'll now dive into treatment. For localized disease, the best treatment is surgery. And the surgical techniques can be surgical technique choices can be lobectomy or sleeve resection. And surgeons can discuss with you in more details about this as well. Sublobar resection especially is possibly an alternate acceptable option if complete resection can be achieved in especially in peripheral tumors, which are like less than 2 centimeter of typical carcinoid as well. And when we say R0, which means that the whole cancer lesion, 1.8 centimeter, 1.9 centimeter, was completely removed, and when those lesion was checked under microscope by pathologists, they saw that the margins were without any cancer, which is called that the margins did not have any cancer present. And that is called an acceptable alternative with this R0 resection. In node positive disease, which means when the cancer has spread to the nearby lymph node, the prognosis is a little bit poor. And in these cases, even if the surgery is done, we try recommending adjuvant strategy based on individualized patient case scenarios. Adjuvant strategy, which literally just means giving a treatment after the surgery was given or after the surgery was done. There are currently no standard treatments or no standard guidelines for adjuvant strategy for neuroendocrine tumors, and therefore more and more clinical trials are needed as well. However, if there was a high risk disease, if the margins, which I explained that when the cancer is removed and then the pathologist saw that the margins were still positive for cancer, in those kind of cases, or when the surgery is not possible, in such situations, chemotherapy in combination with radiation therapy could be a preferred option and can be given to the patients. In metastatic management, when the cancer is already spread to other parts of the body, there are four pillars in this kind of neuroendocrine tumors. Somatostatin analogs, targeted therapy, chemotherapy, and radionuclide therapy. And in next few minutes, we'll go through each of them briefly and quickly. So first and foremost, somatostatin analogs. They form the frontline backbone for SSTR positive, which is somatostatin receptor positive disease. Octreotide and lanreotide, those are the two main treatments available. And they serve as the frontline backbone for this treatment. Usually they primarily work by blocking this SSR2 and SSR5 receptors. And clinical evidence is identified by a SPINET phase 3 study design, which particularly looked into lanreotide. And similar study was also done for octreotide. But here in this slide, I'm highlighting the one for lanreotide, just showcasing some important features and numbers. So median progression-free survival was 16.6 months versus 13.6 months, which means if a patient is not given any treatment, as an average progression-free survival would be around 13 to 14 months. However, if the same patients receive lanreotide, then the average median progression-free survival, which means that average survival without even progression seen in your disease, would be 16 to 17 months, which is really high, many months more as compared to not taking any treatment. And that's why we get the hazard ratio of 0.90, which means that there is a 10% improvement in progression-free survival or living without progression. Very often, you would see oncologists talking about hazard ratio, or you would look into online content and online information and you will find this hazard ratio as well. It's very important to understand what is hazard ratio. It's usually based on the range of 0 to 1 or 1 and higher. 1 is considered that there was no difference. Less than 1, it means that the treatment was better as compared to placebo or as compared to control arm. More than 1, it means that treatment was actually not better. And we'll go through some of these examples in the next slides as well. Safety and tolerability for this kind of treatment is really high. Most common adverse events were only grade 1 and 2, and only 4% of lanreotide patients withdrew because of adverse event compared to 11.5% on placebo, which is really overall indicating that this treatment is quite safe. The second pillar is a targeted therapy. So first and foremost for targeted therapy, there is a treatment called everolimus. It is its mechanism is through mTOR inhibition, and it's a molecular alteration in this particular pathway. And this particular pathway basically blocks the tumor division. So usually in all kind of cancers, you have heard enough that cancer keep on dividing and dividing and dividing. So this blocks one of this pathway, which stops the tumor division and leads to death of those cancer cells or the tumor cells. For everolimus, one of the major clinical trial which gave us information about how this treatment would be working in NETs was Radiant 4 phase 3 trial. It included advanced non-functional neuroendocrine tumors of lung and GI tract. And here the hazard ratio was really great, which is 0.48, which means there was almost 50% improvement as compared to those not taking any treatment. Patients who were on everolimus had around 11 months of progression-free survival, which means for 11 months the disease did not progress at the median average level when looking into the whole patient population enrolled into this trial. This is one of the curve, as you can see. And you can see when the curves, the lines which are above and higher are usually better because the number of patients who are not having progression are higher as compared to those who are not taking any of this treatment.